So now let's take a recap of pediatric hip, starting with the LIMP. So the causes of LIMP in less than 4 years of age are DDH or congenital dislocation of hip, cerebral palsy, infantile coxa vara or muscular dystrophy. In 4 to 8 years, it is Perthes and polio. And in 8 to 12 years, it is SCFE, slipped capital femoral epiphysis. And with a painful limp, remember these all were causes of limp. And if you are talking specifically about the painful limp, in which cases pain is there with limping, the causes are Perthes disease, SCFE, especially the unstable variant, osteochondritis dissecans of the knee, and any inflammation or trauma involving the joint lining and surfaces of hip or knee joint. Now, developmental dysplasia of hip or DDH. So, risk factor, first born female. So, first born female and crowding phenomena. Remember, crowding phenomena is associated with congenital dislocation of knee, congenital muscular torticollis, metatarsal adductus, etc. So they are all because of crowding phenomena in oligohydramnios. What is the pathology? The basic pathology lies in a shallow acetabulum. The femoral head is normal. It is just the acetabulum which is shallow and not able to contain the femur head. So shallow acetabulum, in some cases deformity of femur also. And it is associated with hypertrophy of ligamentum teres because of subluxed femoral head. So what will the clinical features? Painless limp. But this limp can become painful because of the developing osteoarthritis. The joint is subluxated, the femoral head is outside. So because of secondary osteoarthritis, it can become painful. And the typical gait is waddling or duck-like gait with compensatory lordosis at the spine level. So this is a functional lordosis at the spine level and genu valgum, right? And what will the clinical signs? On inspection, there will be a shortened limb because of proximal migration of femur in a dislocated hip, asymmetric thigh folds, and a flexion, adduction and internal rotation attitude. On palpation, we feel feeble femoral pulses. That is called a Narath sign, vascular sign of Narath. The femoral pulses are feeble because underlying bony surface, bony femoral head is missing for the palpation. On movement, we do Ortolani test. Now Ortolani, O is open. Open means that you do the opening movement for performance of the test and the joint is already open. So in Ortolani test, the joint is already open, that means it is already dislocated, and you do opening movement, that means abduction for reduction of the joint. So Ortolani test is one stage in which you open the legs and to reduce the already opened joint. So that is Ortolani. And Barlow, B is by, that means it is a two-stage test. First to dislocate the hip joint and then you relocate. Then there is telescopy, that means thumping the femur and feeling the excursion of the femur head. On measurement, we measure the shortening of the limb in the form of Galeazzi's or Ellis sign. There is Trendelenburg gait because of the disrupted abductor mechanism. The lever mechanism is missing, and von Rosen sign is positive. Classic sign, which is basically a finger assessment just like a shoemaker's line. So it can be assessed through classic sign. What we'll see on radiology, first of all X-ray. There are some markers, lines that we see on radiology. First the Hilgen renal line, which is joining the both triradiate cartilage. Then we have the Perkin line, which is a perpendicular drop from lateral edge of the acetabulum. And then we have the Shenton line, the Shenton arch here. Okay. Then we have the acetabular index, which is basically the angle between the Perkins line and a line joining the lateral border of acetabulum with the center of femoral head. Also known as center edge angle of Weber. In pediatric cases, this is the center edge angle of Weber, right? So these are the assessment that we do in X-ray. Usually the femoral head, it lies in the lower inner quadrant. But if the hip is subluxated, then what will happen? It will be lying somewhere here. So that's what we see in Hinckley line and Perkin line assessment, right? In ultrasound, we measure alpha and beta angle. Remember, beta is big, bad. So when beta becomes big, that means when beta is increasing, it is bad prognosis. So in ultrasound, if beta angle is big, it is a bad prognostic sign. So alpha and beta angle are on ultrasound, not on X-ray, not on MRI, they are on ultrasound. And for screening, we do clinical examination at birth, and at the age of 6 weeks, we can go for ultrasonic assessment of the hip for the screening. So how do we treat? Remember, by age groups, how we are treating. In 1 to 6 months of age, we go for Pavlik harness or hip spica. Bachelor's cast, bone Rosen splint and Fricka pillow, they are obsolete. They are not used these days. So the treatment of choice in 1 to 6 months is Pavlik harness, right? And we have to avoid excessive wide abduction and internal rotation, because abduction leads to containment of femoral head. It has to be avoided because that will lead to neurovascular injury and also AVN of femoral head. In 6 to 8 months of age, close reduction is usually difficult, so we go for open reduction and then we put a cast, hip spica, right? And this open reduction has to be done because this hourglass capsule, the contracted hourglass capsule, it hinders close reduction, okay? In 18 to 36 months, that means 1.5 to 3 years, we have to go for open reduction and femoral osteotomy also for the containment of femoral head. In 3 to 6 years, this alone is not enough. We have to go for acetabulum reconstruction. One of the procedure named is Salter's osteotomy. In 6 to 8 years of age, remember, if it is unilateral, then we go for acetabular procedure. If it is bilateral, then we avoid any treatment. And later on, at the age of more than 11 years, we go for total hip replacement. Okay. Now let's move on to coxa vara. So coxa vara, hip is in varus. So normally the angle, the neck shaft angle is 125 to 135 degrees. If it is less than that, then we call it coxa vara. And because of coxa vara, because of decreased angle, there will be disrupted abductor mechanism, change in lever arm, which will give rise to limp and Trendelenburg gait also with a lurch. The causes can be congenital or acquired. It can be because of developmental causes or congenital femur deficiency. That is an abnormal femur. Just like radial club hand, some part of the femur is missing. In acquired cases, it can happen in SCAFE, slipped capital femoral epiphysis and Perthes disease. And clinically, it will give rise to painless limp. Limb will be shortened because the angle is changed. There is proximal migration of the shaft of femur. So there is true shortening of the limb. Abduction becomes limited and Trendelenburg gait is positive because of disrupted abductor mechanism, disrupted lever arm. On radiology, what we see, neck shaft angle less than 120 degree. This is basic definition. Coxa vara. The epiphyseal plate, which should have been somewhere here like this, becomes vertical because the angle is reduced, and we see a triangle here known as Fairbank triangle. So this is seen on X-ray, and the basis of treatment is HE angle, Hilger-Renal line and epiphyseal angle. This is the Hilger-Renal line and this is epiphyseal angle. If it is less than 40 degrees, that means it is somewhere here. So that means head is like this. So less than 40 degrees, normal, nothing to do. 40 to 60 degrees, we go for observation. If it becomes less than 40, then we keep it conservative. It becomes more than 60 degree, then we go for subtrochanteric valgus osteotomy. That means we take out a bridge, we introduce a valgus here, and that's why this whole part will be rotated and neck shaft angle will be relatively reduced. So subtrochanteric subtrochanteric. It is happening at here, not here. Subtrochanteric valgus osteotomy, right? Now let's move on to Perthes disease, also known as coxa plana, that means a plain hip, osteochondritis deformans juvenalis, or osteochondritis dissecans of the hip. Remember, it is the most common cause of LIMP in 4 to 8 years of child. Causes, it can be idiopathic with a positive family history and there is exposure to smoking, right? What is the basic pathology? Osteonecrosis of the femoral head, subsequent remodeling. So there is first osteonecrosis because of the decreased blood supply and then there is subsequent remodeling of the hip. So typical presentation is 4 to 8 years old male hyperactive child. This is a typical presentation. LIMP is the most common problem and pain comes second. So it is a painful LIMP. So LIMP has to be considered first, then the pain. And because of the change in the shape of femoral head, because of osteonecrosis, there is restriction of Faber, flexion, abduction and internal rotation. Then there is scatral sign also. What is scatral sign? When we try to flex the hip joint, usually it comes into the mid clavicular line, but because of change in the surface of the femoral head, the knee goes into the axilla. So that is known as scatral sign, and that is also known as axis deviation in adults, avian, also in scaphy. That we'll read later on, right? And there is absolute true shortening of the limb because of deformed femoral head. Now the staging, it is done by a Waldenstrom staging according to the stage of the process, whether it is stage of necrosis, whether it is stage of fragmentation, stage of remodeling, etc. So Waldenstrom staging is for disease process staging. And if we want to classify the disease at the time of presentation, when the patient is coming to us, we get an X-ray and then we classify according to one of these three classification: Cattrall system, Herring's lateral pillar and Salter-Thompson. So these are classification at presentation. This is staging of the disease, how the disease is happening. And if we want to predict a prognosis at the end results, then we have to use a Stulberg classification, right? On radiology, first we obtain an X-ray. As I told you, it is a osteonecrosis happening. So because of osteonecrosis, the joint will be irritable, the hip is irritable, there is effusion in the joint. So because of effusion, there will be widening of joint space, asymmetry of the ossification centers because of osteonecrosis happening inside there. And if there is osteonecrosis, then there will be whitening or sclerosis also because of lack of blood supply to the femoral nucleus. And ultimately there will be flattening of the femoral head, and if it gets blood supply again, then it can become a bigger head also during the process of remodeling. So that will give rise to coxa magna. And remember, MRI is the investigation of choice because that will tell us about the lack of blood supply to the femoral head. How do we manage? So now the femoral head is getting damaged, we have to contain the femoral head into the acetabulum so that it can remodel in its normal shape. So aim is containment of femoral head, whether we do it with the help of Petri cast or a broomstick brace, or we can do it with the operative method, which is a varus derotation osteotomy of the femur, Chiari osteotomy of the pelvis, or chilectomy. Chilectomy basically osteotomy at the femoral head level. Prognosis, remember, better prognosis with younger age. The early the onset is, the better the prognosis is, the shorter the duration of disease is, the better the prognosis is. And there are something called head at risk sign, which should ring a bell about the poor prognosis. So head at risk sign, just remember all the 4 head at risk sign. They are very important and they are asked in the exam straight away. Lateral subluxation of head, speckled calcification, gauge sign, which is basically radiolucent V defect at the femoral neck, and sagging rope sign, right? So these are the 4 head at risk signs. Now you move on to SCFE, that is slipped capital femoral epiphysis. Remember, it is a misnomer. Why? Because it is not the head which is slipping, it is basically the distal part, because we define the deformity according to the attitude of distal part. So distal part is going proximal and anterior. So it is not slipped capital femoral epiphysis, it is basically slipping of the distal limb in respect to the femoral epiphysis. So this neck will go anterior and proximal, right? So what is etiopathology? It is basically stress on the weak physis. The weak physis can be because of hormonal problems, collagen diseases. Excessive pressure can be because of rapid growth, rapid increase in height, increase in body weight, right? And remember, the slip, the physeal slip is happening through the cartilage, and it is happening through the hypertrophic zone of the growth plate, the physeal cartilage, the hypertrophic zone. Clinical features. Clinical features, SCFE can present as an unstable type or a stable type. Unstable is an acute presentation that presents like a fracture. So there will be pain, tenderness, excessive pain. So it presents like a fracture. And a stable type is a chronic variant which is slowly happening, so it will be painless type. Remember, it is more in males, and the age group for boys is 13 to 15 years, 11 to 13 years. Why? Because it is the age of rapid growth, second growth spurt. So this is the age. And there is restriction of flexion, abduction and internal rotation with axis deviation, just like Perthes. In Perthes we call it Cattrall sign. Here we call it axis deviation. Basically mean the same. How do we assess? On X-ray, we draw a Kleene line, which is a line along the superior border of neck of femur. So Kleene lines normally cut a portion of the head of the femur, normally. But in cases of SCFE, the head will somewhere be here. So Kleene line will not cut this head of the femur. So this is known as Trethuen sign. Then we also get a Steele sign. Steele sign is basically increased density in this area because of overlapping of neck of femur with the femoral head. So that is a Steele sign. And the view that we use for the assessment is frog's lateral view for mild slips. We can make the use of MRI for the assessment of SCFE, ongoing SCFE, and we can also make the use of technetium-99 scan to see what is the complication happening. If there is chondrolysis, that means regeneration of the cartilage, then there will be increased uptake. But if there is decreased uptake, that means there is less of blood supply in this area. So hip is going into AVN. So that is the use of technetium-99 scan, right? How do we treat? Unstable is presenting like a fracture. It is acute slip. We can reduce it. So we reduce it and we fix it with pins. In chronic type, we cannot reduce it because it is stable, it is fixed, it is joined. So we can just reduce the further slip. So we go for in situ fixation in that position only, right? So that will be all. Thank you.